Hi, everyone. My name is Ellen Holmes. I'm a respiratory therapist and educator with the Lung Health Program. I'm here today to talk about advanced care planning. Many of you have probably already done your wills and possibly have an advanced care plan set up and discussed with your families and your substitute decision maker on what you would like to have done if you're not able to speak for yourself. In a crisis situation, if you're able to speak for yourself, you are the one making the decisions. You're in the driver's seat. But if you're not able to make those decisions for whatever reasons, then your substitute decision maker will be making those decisions on your behalf. So you need to find someone that you trust that will respect your beliefs and values and wishes and follow through with them. So without further ado, I'm going to share my screen and set up the presentation and we'll begin. Thanks, everyone. Okay. So what is this advanced care planning? For those who haven't heard of it, it is a way of sharing your wishes for your future health care. Who would you like to speak for you if you can't speak for yourself? How would you want your care directed if you're not able to make those decisions yourself? And how would you define your quality of life? That's a big one. Try to figure out what's important to you in quality of life. I don't want you to dwell on it or focus only on it, but it's good to reflect and think about what would happen if a critical situation, a crisis happened to you. So knowing what you want at the other end, the quality of life, outcome, then that's what you have to kind of keep in mind when you're going through the process of setting up your advanced care plan. You need to reflect on your wishes and values and beliefs and have important conversations with you ones you love. It's all really, really important. So step one, think about what's right for you. What are your wishes, your values, your beliefs? What is important to you? Does anyone know how you feel? Or is it all to yourself? If you develop a health condition, which may result in you not being able to speak for yourself or recognize your loved ones, such as dementia or Alzheimer's, how will you make your wishes known? Who will make decisions for you? Have you experienced death with other people before? How did this go? How did you feel about it? What kind of medical inventions would you want? What kind of medical interventions would you not want? What would be meaningful for you at the time of your death? These are things that we should think about from time to time. Step two is learn about what people do, what healthcare providers do in the hospital setting. Learn medical terms and treatments that can help make your decisions better. Help you have a better plan. Learn more about your current health and what your future might look like if it progresses or if it could possibly get better. Learn about different medical treatments and what they can or cannot do for you. Some individuals may decide that they would like all medical interventions. Other individuals may not want any medical interventions. Some individuals may want some in this situation, but not in this situation. There is no right or wrong answer. It is your decision to make and your decision only. You just need to share it with your loved ones and friends and neighbors if they happen to be the ones checking in on you. So step number three, make the decision of who you would like to make decisions on your behalf if you're unable to do so. So the person should be a partner, a sister, brother, a close friend, or it could be a neighbor. This person should be designated as your substitute decision maker. The decision maker should have the same values and beliefs as you, but if they don't, they do need to give you the confidence that they respect your values and beliefs and wishes and will follow the wishes that you have outlined, either verbally or on paper in stressful times. Your substitute decision maker, just trying to get this out of the way, is only called upon if you're not able to make those decisions. If you have a written document, your substitute decision maker can use it to guide your care and advocate on your behalf for your wishes. Step number 4, have the conversation. These conversations may not be easy. It may be very difficult for some family members to listen to them. But if the approach is on a more casual level and just letting them know that this is really, really, really important to you, and that you would really like them to understand, and it is only if you're not able to make the decisions for yourself, it generally will go better. Start talking to your substitute decision maker, your family and healthcare team. It is important to regularly review your wishes for future healthcare and communicate this with your substitute decision maker, especially if your health changes or if there are any major changes in your life. Your substitute decision maker may not be able to make those decisions for you, so you might need to have the discussion with another substitute decision maker and name them as the person that will speak on your behalf if you're not able to. So step number 5 is documenting it. And this can be done on paper. It can be done by video. It can be done just by talking to somebody. It should be somewhere, though, that other people can see it and recognize it. Make sure your substitute decision maker has a copy and ensure that your family knows where it is. It is a fluid document. It will change over time. I started making mine at 28 years of age when I had my first child, and it has changed quite a bit over the years. It's not a bad idea to revisit it annually or maybe every other year, but it is a good idea to revisit it and have the discussion with your substitute decision maker and families together. Having deeper conversations with your healthcare providers will also help you decide what you would like for the end of your life, if you will. There are lots of options, and knowing what the options are is a really good place to start. And making a decision at the time of which you would prefer out of all of them. There's hospital admission and staying in a hospital. There's also palliative care, that you could have your palliative care team come into your home and you can stay in the comfort of your home with your loved ones around you, your favorite duvet, your pets, etc. Or hospice care, which would be in another facility. Sorry, move this out of the way again. It would be another facility where they would look after you, but you could still have your favorite duvet and things around you that make you happy and comfortable. We now have medical assistance in dying. It's called MAID. It's a process where a person seeks medical help to end their life based on their life-limiting health condition. It's a deeply personal choice, and great care is taken to ensure that the right choice is made for the right patient. It's not a quick decision, and there is quite a bit of in-depth conversation with other healthcare providers to make sure that this is the right thing for the individual, for you, but you're the one at the steering wheel, and you're the one that has to make that decision. On the left-hand side, you'll see a form. This is sample across it. It's called a do not resuscitate form. You've probably heard of these. Your clinician, your doctor has to, or nurse practitioner would have to get this form for you and fill it out with you in order to have it implemented. And what it does is it tells first responders like police, firefighters, and ambulance paramedics that you do not want life-saving measures. It is for that and only for that when patients go to the hospital, and even if they have a do not resuscitate form, they still may be asked the question, or the substitute decision maker may still be asked the question of whether or not you want full resuscitative measures. So if you do have one of these, once it's completely filled out, you can make copies and give them to people so that they know. Keep one at home, get handy so that whoever is with you can present it if someone calls 911 by accident and has first responders going there. Typically, the physician will say the idea is not to call 911, to allow the person to pass respectfully and peacefully in their home. But if 911 does get called and they're presented with this do not resuscitate form, then resuscitative measures will stop and comfort measures will be given. So pain relief, oxygen therapy, things like that will be given to ensure comfort of the patient, but resuscitative measures will be terminated. So that's in a nutshell what that means. You would need to have the conversation with your primary care provider. So there are resources out there, Speak Up Ontario, Dying with Dignity, Advanced Care Planning. You can always contact any of us. We can very happily set you up with those resources. They're all good. They're all very, very helpful. Some give you more option to write what you want, what your wishes are, to express your feelings, and others are more prescriptive. They give you more of an idea of the resuscitative measures that healthcare providers may do in a crisis situation. So you can have a look at all of them and see which works best for you. But that's it. And I thank you so much for listening today. I'm just going to stop sharing my presentation, and it is time for Q&A. So I'm going to hand you back to your moderator. Take care, everyone. Bye for now.